Welcome back to our Health Cog Extra, What Next for the National Health Service. I'm Tabitha Goldstorp, the co-founder of CogX, and it's thrilled to welcome you wherever you are today. Don't forget to check out the expo and drop a line to some of the brilliant organizations showcasing their innovations. Now, unfortunately, because of constraints owing to the pandemic and the all-important work he's doing, I have to tell you that Matt Hancock, the Secretary of State for Health and Social Care, is unable to make it for today's fireside chat. We really apologise and hope he makes it back to CogX very soon. He did, however, leave us a short note, which we will watch in a moment. And then after his video, I have the pleasure of bending your MC for the day, Jack Kreindler's arm, who was going to interview Matt. I've convinced him that we should use the time to have a quick review of today's Cog Extra and talk about some of the topics that have been brought up. So after we've listened to Matt, I will welcome Dr. Jack Kreindler and we will have a chat. And so please do ask your questions. So if there's anything you've heard today or you're going to hear later today and that you would like to hear from someone as illustrious as Jack, I will be your interlocutor and we will get to some of those questions. So before we do that, let's hear the video that Matt sent us a few minutes ago. Can we roll Matt's video, please?
I'm really sorry I can't be with you at CogX this year. It's such an important agenda, and in the space of healthcare, which of course has been so critical this year even more than ever, we've seen incredible advances in the use of technology to help to protect our NHS and ultimately to help to protect lives. I want to thank everybody who's been helping with that. Unfortunately, the nature of the pandemic means that I'm not able to join you in full. But I know that it's going to be a brilliant and rich agenda, and I want to say all power to your elbow in using modern technology to improve the world around us.
All power to your elbow. That is a very good message for us all. Nice to have a health minister who is so pro the right kind of uses of technology. So let's bring Jack on. All power to your elbow, Jack. Are you there?
Yeah, my elbows are all powered.
Good. Well, I mean, I have to say, I thought, I spoke to Matt this morning. I thought he looked really, really, very tired. And it's not just him. The whole health system is tired. The NHS is tired. The people on the front line, the nurses are tired. You're tired. What would you do? Let's go in really hard. What would you do if you were a health minister for the day? Or no, let's not even give you health minister today. You're health minister for the next 5 years. What would you do?
Yeah, I was actually going to say it's a tough job, right? I don't think anyone can really prepare themselves for this kind of scenario. In general, extremely high pressure environments are things that you train for. Actually, you don't simply appear at and land yourself in and hope to deal with. You're supposed to prepare for them. In my area of specialty, which is in extreme environments, physiology, and like areas like mountains and deserts and so forth, it's you don't just land yourself there. And so this sort of job, if I was a health secretary, I would probably have gone through years of going through political experience and been appointed to that lofty position and probably be able to handle most things. But quite honestly, this is not something that is in the standard playbook of anyone, the situation that we're in at the moment. And those kinds of excess stresses do play a very important role in both how we react to things in the short term and long term, and ultimately for how long and how healthily we live. So it's kind of a paradox here that we're sort of sacrificing some of our own health to deal with saving the health of and health systems for others. Not an enviable position. What would I do? Number one thing, if I could do anything, protect my sleep. I think that's the fundamental golden ticket to survival, short term and long term, is preserving how much recovery we get at night. Yeah, not an easy thing to do when you're working 20 hours a day.
No, that's a good piece of advice. And you're an expert, as you said. Your specialist areas in high extreme areas like mountains where people are very alone. And it reminded me of a lovely quote from the session we had earlier with Chrissy Watson, the author of Courage to Care, A Call for Compassion. She said, when we feel most alone, nurses remind us that we're not alone. And I think in this pandemic, more so than anything else we've ever seen, people are alone. And I'd love to hear your thoughts. I know that you're a big supporter of patient-centric care, but what do we do about caring for those nurses that are literally feeling alone in this scenario?
Yeah, I'm sorry about the buzzing you might hear in the background for some reason. I do apologize. This is another symptom of this kind of working remotely. Loneliness is not really a big feature in the international classification of disease. I think it should be, and I think that what Christie's book talks about is the fact that excellence in medicine is not just about kind of the hard outcomes that help you then market a drug, like how many years you live for, but it's actually about the compassion, kindness, and care that the system, the health system that is run by nurses more than it is in fact by doctors. That is really the core component of what it is to deliver excellence in medicine, and the outcomes of how long you live, progression-free survival, those kinds of things are of course the hard metrics. But medicine's not just about hard things; it's also about the softer and more care-orientated things, and loneliness, isolation, a lack of social contact, a lack of family being able to visit you, result in diseases themselves. And I think we're trying. I remember a fantastic quote at the beginning of lockdown by Rabbi Laura Jana Klausner, and she says, you wash your hands of the virus, but do not wash your hands of people. And that's one of the things that I imagine, goodness knows what would have happened if this thing happened 20 years ago and we didn't have the connectivity that we did have through Zoom and various other. Sorry, I don't want to necessarily use Zoom. Microsoft's version or Microsoft Teams. Yes, there you go. That's all true to the sponsors. Sorry about that. But yes, I think you get the gist. It's you can just kind of imagine the degree of isolation and the degree of dis-ease. And I use that word very specifically, the amount of dis-ease and then illness that results from isolation and lack of care. It's late at night on the wards when the people are feeling their very loneliest and most vulnerable. I'm not talking about COVID. I'm talking about the whole of history of being isolated, quarantined on a ward in a hospital away from your loved ones. It's not the doctors like me that are wandering around. I mean, actually, I was a bit stupid because I got no sleep whatsoever when I was first couple of years of being qualified. I used to wander the wards at night, chatting to patients, and ending up getting probably biologically older much quicker than I should have. Certainly grayer follicles on my beard. But that is the absolute. It's not even the job. It is the natural care that nurses give that doctors don't, and it's something that we completely forget, utterly undervalue, and I personally don't think it's right. Equal pay for nurses and doctors, I think is something that should seriously be considered, and that might be a very radical and apocryphal thing to say, but I have a feeling that will change at some point.
I think there's definitely a discussion that needs to be had. There's a sort of an awakening of what a key worker means now, and how that's then remunerated. Your quote from the rabbi it rings true for me from another way. If I think about you must wash your hands, but not wash your hands of people. It's a similar quote that you could apply to artificial intelligence. We must use AI, but we must not forget about people. And the other sessions we've had today have really been digging into what the NHS is doing around artificial intelligence. And we had Indra Joshi and Simon Madden talking about the work they're doing at NHSX. What are the recent developments in technology that you've seen that most excite you and give you a kind of an optimistic view of the future?
Right. Well, you see, so my view on tech AI is that actually what it should do is it should ultimately give us more time to care. So it actually wraps very, very closely into the roles of medical professionals, not just as the doctors, the physicians, but as the priest, the nurse, the bartender, the friend to the patient. We can't deliver a difficult cancer diagnosis today by giving you an extremely shiny app with a really, really nice probability distribution that you have got 6.4 years to live, because that's exactly what the AI has quite correctly said. And by the way, that's great, because normally you would have been given 2 years to live and a kind of finger in the air as to what you were supposed to be given to get you there. Now the AI will help analyze and molecularly diagnose and scan the pathology slides and radiomically analyze what the radiologist can't see and come up with your 6.4 year solution. You don't deliver that on an app.
No.
But you certainly don't have the time as a team of clinicians today. And a lot of work has been done. I think it's the Oxford group and the Integrated Cancer Medicine group, Professor Richard Gilbertson's group in Adam Brooks and CRUK's Lee Ka-shing Institute around molecular tumor boards, etc., who would have to really spend 10 times the amount of time they spend with patients today, i.e. it's impossible to go through all of those sophisticated data and next generation diagnostics to be able to practice better oncology. Now, that's not possible with humans alone, so that's where the AI comes in. But really, the ultimate purpose of the AI is of AI in medicine for me, and this is where I see its golden use, is to deliver better diagnostics and treatment plans, or assist people in doing so, but then actually leaving more time for us to properly care.
Yes, yeah, that sounds the dream as a prospective patient, not prospective, a patient I hope never to have to deal with something like that. No, but it's still it makes me feel like there is, we're on the right journey towards hope, towards early diagnosis. My challenge is that whenever I talk to some of the incredible companies doing work in this space, like Microsoft or startups like CareOnMed, it's still in a hospital, 1 or 2, it's still at trials phase. And the session we had this morning with Microsoft around building interoperability, there was just time again, commentary around that data isn't in the right format. People are still writing things down. We're so far away from being able to actually use a lot of the technology that's there. How do you think we can turbocharge that kind of input piece? Yeah,
I mean, Indra's right. I mean, the Microsoft work stream on this is really important as well. I mean, it's not just, everyone's trying to do this. Interoperability is utterly essential. And a lovely example of this is how it really doesn't matter which airline you're on, which language is the native language of the pilot, which country you're flying to. There is so much interoperability, for instance, in what it is that you communicate and how you do that, at what time, in what format, to different air traffic controls, that you can quite safely do this. Imagine 150 years ago, the concept of throwing thousands of aircraft into the sky, all kind of needing to know who to land where, and it is just baffling to think how that organically evolved. And I think what we've got in medicine is we've got a massive regional, national and international network of clinicians and hospital systems, which, a little bit like airports and networks of airports, have been built independently of each other. They and the interoperability between them is now being retrofitted, and so we all understand that in order to capture in real time what we've learned from each patient, to be able to share that with the doctor next door is enough of a challenge, let alone pooling that in a federated learning, privacy preserving way, so that, you know, kid with particular issue X with genomic background Y treated with Z did better than this other way of doing it, and actually help the kid in Great Ormond Street to benefit from that, and vice versa. That level of interoperability is utterly essential. It's you know, medicine is not as prescriptive and easily defined in terms of, you can't classify the language of how you describe certain things, because basically, as much as we like to think medicine's a very well-defined science with a very solid taxonomy, it's not. It's fluffy, you know. And because it's fluffy, and every time we invent a new genomic sequencing technology or make it faster so that more people are doing it, all of a sudden we realize the disease we thought was a disease is actually 13 different types of diseases. So it's not quite like a takeoff and landing, which are quite well described.
Yes. Well, and do you at med school in 2020, do people learn about how important interoperability is, why data collection is important, what AI is? Is that now part of the training?
Well, you know, when I studied medicine, I think you needed biology, chemistry, and physics, or biology, chemistry, and maths, or something like that. Yeah. That was sort of your if you weren't a graduate of some life science degree, going in a bit older, that's what you had to have. So maths was one of the options, but certainly not data science and data integration, and just in general. I mean, is there an A level for data? I don't know if there is quite yet. I mean, I was a bit ectopic because I was allowed in with biology, chemistry, and fine art, believe it or not. I think I was the only person in the history of medical school to be allowed in, and, you know, look at all the mistakes I've made since. That's probably the last person that would ever be allowed to be admitted with that. But certainly I would say that most medical students today should actually be taught either, you know, at A level or taught as an entry condition about data science, and if you want to call it AI, call it AI, but essentially the core components of communicating complex information amongst colleagues and amongst each other and for research. It's not something that comes on par with biology, and it should.
And I'm no expert in pilots, but I'm pretty sure that the training pilots get is probably updated every 3 to 6 months based on the technology changing. So I don't know. It makes me feel like we have a lot more work to do in making sure that the people that we're asking to use these tools are given the tools to learn about them. Moving on to tools, my new favorite thing is the wearables. I've gone full-blown tracking. Since I had my little boy a year ago, I've become obsessed with tracking myself. Tracking him. I even bought my partner a full-blown printout of beautifully illustrated of the first 3 months of his eating and sleeping and crying. And it's this beautiful data visualization, not beautiful to anyone except for me. But I've gone like, you know, and I'm a healthy person, but I've become quite obsessed. And so is Eric Topol. Obviously, we have Eric Topol later today. He's doing this 40,000 person participant wearable study, which I desperately would like to be in. What are your thoughts? Do you track yourself? Do you suggest your patients track themselves? Are you tracking yourself on your ring? I see.
Like, this is not product placement, but this is the wearable that I prefer at the moment. The reason I like this particular device is because the battery life is 5 days and it takes 10 minutes to recharge, so it kind of, you don't get any of those issues. It's kind of cute, and this is you know, like a very, very, very good way of monitoring sleep. Back to my original point about how you're going to survive tough conditions if you haven't been trained for it. Protect your sleep. That is my big weakness, and this is particularly good at reminding me at how absolutely appalling my sleep architecture becomes when I go to bed too late. I'm stressed. I use my device without turning it onto mode, night mode, and all of those wonderful things. And it is jolly helpful. But then again, I'm something of a geek. So for me, this particular device is really good because I get fancy graphs and those kinds of things. Where I think the next bridge needs to be built is how do you get those kinds of insights built into kind of just pervading what it is that you do without having to interpret graphs and data and stuff. You're a bit of a geek too, I have to tell you, Tabitha. I'm not, this is not a formal diagnosis, but you are. And so, like myself, you benefit from these things. But there's a great amount of work being done by Esther Dyson, for instance, with the Wellville initiative, which is huge democratization of more passive changes in people's lifestyle and behavior from those data, but with ever simpler devices that don't need geeks to kind of interpret. So that's where I think the future is going with these things. I guess I feel as if we're in version 2 or universe 2 of generation 2, should we call it, of these kinds of apps. The first generation they were big and clunky and people didn't like wearing them. Now people like wearing them. And the third part is that people that neither really like wearing them nor have the ability to geek out on them will ever more frequently benefit from them.
Yeah, and if that's generation 2, I feel like I'm starting to see a sort of generation 2.B, whereby my friends who did used to wear them or just hadn't even thought about it are now thinking about it and going, but who's now tracking me? So I've had, I first went for a very affordable Chinese company's tracker, and my partner's first thoughts were, great, so now the Chinese know where we're having lunch. And I was like, hey, they don't care. What do you mean? This is not the way. And then when I bought the Apple version, I got now Apple is tracking us. And I tried to explain the way Apple technology works. And that's not really what people want to, even if you explain the full decentralized model, people still feel being tracked. And I think this is obviously what we're seeing with the track and trace. Yes, we've had 10 million downloads, but there is a kind of a reluctance and a fear of what, an unknown baddie is doing. And then there's obviously a fear of actual baddies are doing. We've seen things like the Social Dilemma movie. We know what happened with Cambridge Analytica. There's so much to be fearful of. How do we overcome that and make sure that we're using the best of this technology?
Well, you got to start the conversation with addressing the fear versus flogging the cool bits. That's if you flog the cool bits, then people that don't care about they have no fear. They won't care. They'll just say this is cool. So that's what we're doing right now. And I think we're suddenly realizing actually there's a very, very large number of folk, some of whom, by the way, have a pretty good point in terms of, because if you do actually dig quite deeply, health information is not category information. It can know an awful lot about you, but you are allowed to do things with it that are not compliant with HIPAA. And it's only medical information that is really held as sort of top category, sort of private information. And the rest of it, you can almost do what you want, sell what you want, manipulate the minds of who you want. You can do quite a lot of stuff with health info. Right. And actually quite a lot of, I've seen a lot of startup pitches where, it's still very much and the real reason we've built this with this wearable because of the data. And, imagine what we can do with the data. And I'm asking, imagine I would like to know what you would like to do with the data and who it gets sold to and stuff, because I just want, I think it's polite. It's actually plain etiquette to tell me what you're going to do with all this data that I'm paying for you to collect, which is sort of seems like a double dip on their side. So I think the answer to your question really is every company that really has, if they genuinely are passion and impact led, which is what a lot of them claim to be, then start with this conversation about, I know you're worried about it. We're genuinely definitely here for the benefit. We will obviously, make a margin, even make a profit if we add genuine value by extending your life, making it better, reduce your number of chances that you go to hospital, make you run faster for a bus and things like that. But start with that conversation versus pretend it doesn't exist.
Totally. And that's such good advice. I hope there are startups and big tech companies listening, because I think that flipping the conversation around like that is really good advice. I hear a lot, and we've even heard it today, people talk about the need for public trust. And there's an amazing philosopher called Honora O'Neill that rings in my mind that says, no, we don't need public trust. We need, corporate and government trustworthiness. And so the question now for us, I guess, is, do we need to regulate for what you've just suggested or create new standards for what you've just suggested? Or can we trust companies to be trustworthy and do as you said, because they believe that that's how they're going to maintain their social license to operate? Or do we need to be stricter? Does the government need to be stricter?
Yeah, I mean, it'd be nice to know what it is you are trying to regulate first.
Of course. I mean, yeah.
So I think regulation always happens late because you don't know what it is that you need to regulate. You kind of almost have to wait for the ripples in the pond to settle before you kind of go, well, let's try to avoid this, ghastly splash next time. So I think we're still in sort of, pond ripple settling mode at the moment. But yeah, I think a degree of either good etiquette, sort of, really solid open standards where it's sort of glaringly obvious, I should say, that this company ain't, singing from the hymn sheet it should be, offering, charging you for the use of something free like the internet would just, market forces would dictate that those people wouldn't end up winning, or whether it's kind of regulated from at a government level. But let's be really clear here, and this is something we're seeing with COVID as well, is that one can really interoperate between countries very easily at the moment, between who's had the right kind of test. So can they come from New York to Heathrow and not have to, they're clear, so they don't have to quarantine, and even those very, very simple interoperability things between countries becomes a problem. And so if you are going to regulate them, are you going to regulate them for your country, or does it become some kind of international regulation? Is it done by done by departments of health, or is it done by the World Health Organization? I mean, I think these are not easy things to regulate at all. And I think also you've got to bear in mind that the more you regulate, the more you kind of inhibit the free market the way to explore those things and see which ones work and which don't. I haven't seen as much, I haven't seen significant, really decent evidence yet that anyone's minds have been grossly manipulated, voting tendencies changed as a result of wearables like this. I think there are bigger fish to fry out there in terms of who's doing what with our data and modeling behaviors than things like wearables. But it's certainly something to look out for.
Definitely. Well, we'll hear more from Eric Topol next, and then the Tony Blair Institute session at the end of the day. So for the last 2 minutes, I want to come back to a personal question. So when the pandemic hit, Charlie and I called you pretty much first, probably on the same call. What do we do with our team? What do we do with our families? It was like a kind of gut reaction of fear, and as you said, sort of unease, dis-ease. What's your advice to people listening now? We all get the cough and a cold. Have we got COVID? Are there enough tests? Genuinely, what do we do as the rest of winter sets in?
Yeah, look, the attack rate of the virus is not 80%. That's we're not planning mortuaries underneath Hyde Park. I mean, these were things we were talking about. 6 months ago. This was we were building super hospitals as clearinghouses for the sickest at the Excel Center. Remember that?
Yeah, the Nightingales.
Yeah, exactly. So just remember that we did genuinely have this scenario, the worst realistic scenario was pretty bad, and that can happen again in future. It might in our lifetime, I hope not, but I think although we're better prepared for it, I think the reality is that we were a lot more scared there. I think the key thing now is that the message has got to be about responsibility to others, either ones you love or older, more vulnerable people in general. Your flu jab that you're all going to get this year, and if you don't do it yourself, Tabitha, I will come round with a jab and jab you.
I promise.
It's out now. It's not for you, Tabitha.
Yeah.
It's to stop you from getting it as badly, then giving it to grandma or someone in your office that's going to. Same with COVID. It's like, take care of others, even if you're Superman yourself. And I think that's where we've changed, is that this is no longer a thing of, oh my God, are we all going to die in the office? It's how do we build a sense of responsibility? And if everybody develops that sense of responsibility, starting in the workplace, is my humble opinion, you will see cases. Well, I don't know if you'll see cases go down as much, but certainly the number of people that end up in hospital will, because that's really the key point. Yeah,
I love it. Let's end on that message. Let's keep caring for each other. I mean, that should be, if that's the thing that comes out of the COVID pandemic, that is really, really exactly what should be happening. I care for you, Jack. I'm going to go and get my flu jab. I care for everybody on the line. Thank you so much for tuning in. And we'll see you in a moment for Eric Topol. Thank you, Jack. See you soon.
Want access to more CogX videos? Subscribe now for free at cogx.co.